Hi everyone, I'm Grace, and today I'll be covering anxiety and personality disorders. Before we start, I just want to touch on the resources I used. So there will be specific references in the speaker notes of each slide, but some general good resources are things like PsyDB, MSc manuals, and therapeutic guidelines. I also want to thank Rose, who covered this topic really well last year. Starting with anxiety disorders, there's one R1 condition and three R2 conditions. Generalized anxiety disorder is very bread and butter, and it's important to know quite well. So unfortunately, this is one of the few conditions where I would make an effort to remember the DSM-5 criteria, as it is quite OSCE examinable. So GAD is characterized by feelings of anxiety on most days for at least 6 months. This feeling must also be difficult to control. If patients are adults, they must experience at least three of the following symptoms as well. They are fatigue, muscle tension, difficulty concentrating, restlessness, irritability, or sleep disturbance. If the patient is a child, they only need to have one of the above symptoms. And of course, symptoms must cause a significant impact on psychosocial functioning, and the clinician must ensure that the symptoms are not due to another cause. And we'll discuss some differentials in a second. So these are the general symptoms. And to help you remember, we have a very helpful mnemonic, which is worrywarts, or WWARTS, and I'll let you read through that in your own time. So now to ensure that the symptoms are not due to another cause, differentials have to be considered. So when thinking about this, I think it's helpful to brainstorm which symptoms anxiety shares with organic problems, for example, chest pain, shortness of breath, and palpitations, and outlining differentials from there. For example, chest pain could be caused by coronary syndromes like angina, shortness of breath can be attributed to heart failure, asthma, COPD, and palpitations can be due to arrhythmias. So Monash specifically enjoys including hypothyroidism as a differential, and this is quite common in real-world circumstances too. And they'll often ask questions where a patient presents the GAD-like symptoms, as well as vague hypothyroidism symptoms like weight loss, and will ask what is the best test to order. And the answer would often be a thyroid function test. And this is because hypothyroidism causes a heightened metabolic state and can result in symptoms like shortness of breath, palpitations, and feelings of anxiety. So, after organic causes, other psychological causes should also be considered, in particular panic disorder and phobias. However, these tend to be more episodic, but anticipatory anxiety or avoidance can mimic GAD in circumstances too. And some last things to consider are new medications as well as recreational drug use. So, moving on to treatment, first line treatment for GAD are psychosocial interventions, in particular things like CBT and stress management. If psychosocial interventions are not effective or not preferred, or if the symptoms are too severe, medications can also be added on. First line SSRIs, in particular escitalopram and citalopram. Second line includes SNRIs. It's important to remember that all patients should receive ongoing supportive psychosocial treatment, even if they are receiving pharmacological therapy as well. So while antidepressants are first line, they aren't really effective during acute crisis, as it can take several weeks for them to reach therapeutic levels. So typically, when someone's having an acute flare, benzodiazepines are used instead. Benzos should not be used long term, though, because they have issues of dependency and also other side effects. So in a management-based OSCE station, using a biopsychosocial model to structure your answer can help you remember all the types of treatment available for GAD. So this is just an example here. It's not a perfect answer. You can add or remove whatever you see fit. Moving on to panic disorder. So you don't need to know as much about this one. I think having a general understanding of the symptoms as well as management will be enough. So to be diagnosed with a panic disorder, patients must first experience recurrent panic attacks. So what is a panic attack? The criteria is listed below, but it's essentially an abrupt feeling of intense fear or discomfort during which time the patient experiences many uncomfortable physical and mental effects, for example, palpitations, sweating, trembling, and a fear of dying. So they're getting recurrent unexpected panic attacks. Next, at least one of these attacks have to be followed by at least a month of either persistent worry that additional attacks will occur or maladaptive behaviors related to the attacks. For example, behaviors designed to avoid the attacks. Again, ruling out other causes is necessary, especially thyroid problems. Psychosocial management such as CBT and sleep hygiene come first for panic disorder, but if they're ineffective or not preferred, antidepressants can be tried as well. SSRIs are first line, and you can also add on anxiolytics like benzodiazepines during times of crisis. So now for agoraphobia. Agoraphobia, put simply, is anxiety that occurs when one is in a public place. This anxiety is related to a fear that escape from these places might be difficult, or a fear that panic-like or other embarrassing or incapacitating symptoms may occur. For example, a fear of falling or incontinence is common in the elderly. This anxiety and fear ultimately results in active avoidance of situations that may trigger these feelings. I think an aspect of agoraphobia that differentiates it from a specific phobia is the fact that the fear anxiety is of experiencing incapacitating symptoms themselves, rather than the actual situation or place. So here is the DSM-5 criteria for agoraphobia. I don't think remembering the exact criteria is needed, but I think it's good to keep in mind that this anxiety tends to occur in public transport, in open spaces like car parks, in closed spaces like cinemas, in crowds, or simply being alone outside the home. Moving on to specific phobias. Once again, I think that remembering the criteria is not necessary. The important parts to remember are just that the same situational object consistently evokes the same anxious response and leads to an avoidance of the situational object. And here are some common phobias like animals, heights, storms, water, etc. And here is a helpful flowchart that outlines differentials for anxiety disorders. So specific triggers make you think of specific phobias. Worry about panic indicates agoraphobia, etc. So please read through that in your own time. Moving on to personality disorders. In Australia, personality disorders account for a significant amount of mental health related admissions. It's estimated that 26% of people presenting to emergency departments for a mental health crisis have a personality disorder. So it's important to have an understanding of the various types, and they're all listed here. There are 10 in total, and only one is R1 condition, which is borderline personality, which we'll go through a bit more in depth. So, what is a personality disorder? Personality disorders are enduring patterns of behavior and experiences that deviate significantly from the expectations of individuals' culture. In more simple language, personality disorders result in people seeing themselves and reacting to others in a way that causes problems. These patterns begin in adolescence or early adulthood, are pervasive and inflexible, and remain stable over time. I think the key thing to remember here is that people with personality disorders exhibit patterns of behavior, as a lot of personality disorders, especially exam questions, can look similar to other psychiatric conditions. Finally, as you might have seen on placement, personality disorders are highly comorbid with other personality disorders, and there's significant overlap between the different clusters, making diagnosis challenging. So, in a nutshell, personality disorders can cause impairment in people's lives by affecting their cognition, meaning the way they perceive themselves, others, and the world, the range, intensity, and appropriateness of their affect or emotions, as well as interpersonal functioning and impulse control. Traditionally, personality disorders have been grouped into three clusters: A, B, and C. Cluster A are considered odd or eccentric, Cluster B are dramatic, emotional, and erratic, and Cluster C are anxious and inhibited. So here are the conditions within each cluster. So starting with Cluster A, so for each of the conditions, I've listed a few lines from the DSM-5 criteria. I don't think it's necessary to remember them, but just use them as a guide to help you develop a sense of what each of the personality disorders present like. So starting with paranoid personality disorder, people with paranoid personalities are fundamentally distrustful and suspicious of others. This causes them to excessively read into others' motives, actions, and words, and as you can imagine, this often results in social isolation. So here's a vignette of a patient with paranoid personality disorder. Anthony is a construction worker who believes his co-workers do not like him and fears that someone might let his scaffolding slip in order to cause him injury on the job. He notices other men laughing together and often wonders if he is the butt of their joke. He gets on poorly with co-workers, unable to appreciate joking around, and does best in situations where he can work and have lunch alone. He had few friends in school and felt that other children would form cliques and be mean to him. He blamed his teachers for his bad grades, claiming that they preferred girls. The patient is distant and demanding with his family, in particular becoming restless when his wife is away visiting others. So clearly, Anthony is exhibiting a pattern of behavior. He has been suspicious and mistrustful in multiple areas of his life, including work, school, and family, for a long period of time. So moving on to schizoid, people with schizoid personality disorders are similarly socially isolated, but for different reasons. The two key aspects of schizoid are firstly that they have affective disturbance and show limited emotions, resulting in difficulty with interpersonal settings, and secondly, that they take pleasure in few things, including close relationships. So here we have Jonathan. Jonathan has always found that he's not able to enjoy life as much as other people do. Even his most intense feelings of happiness are not very intense and don't last very long. He's had these levels of subdued emotions since he was in his teens. He reported that's like being dead inside. Jonathan has been interested in computers since he was 13 and has an advanced understanding of mathematics. Since his teens, he has become exceedingly socially isolated, with his computer as his sole companion. He has never been in a relationship and expresses no desire to be in one. So, from Jonathan's case, we can see that people with schizoid personality disorder have a flattened affect and restricted emotions. They also lack desire for interpersonal relationships. Additionally, people with schizoid personality disorder tend to choose occupations and hobbies that can be done in solitude. So moving on to the last of the cluster A conditions is schizotypal. People with schizotypal personalities have aspects of both paranoid and schizoid, as well as a few unique features. They also experience paranoia and suspiciousness, affective disturbance, and also have difficulty with social interactions. But for schizotypal people, it is due to social anxiety and paranoid fears, as well as discomfort with close relationships. In addition, schizotypal people are often regarded as bizarre or eccentric due to multiple factors such as strange beliefs or magical thinking, for example, being superstitious, as well as odd behaviors and appearance. So here we have Camden. Camden is a 15-year-old boy who has always had significant difficulty relating to his peers. Social situations are extremely anxiety provoking for him, and he is quite socially inept. Since childhood, Camden has been interested in paranormal experiences, particularly ghosts. His mother reports that his interest goes beyond mere curiosity that would be normal for someone his age. Rather, his preoccupations seem to dominate his life at the exclusion of other activities. Camden also reports being superstitious. For example, he believes cats crossing his path is a sign that there is negative energy in his area. Camden was highly animated and often inappropriate, smiling and laughing during psychological review. So, from Camden's case, we can appreciate the social problems, affective issues, and odd beliefs that are hallmark features of schizotypal personalities. A link to the full case is in the presenter notes and will be a good read, as I think it includes many more signs of schizotypal personality disorder. So, in summary, for cluster A, paranoid is about distrust. Schizoid is defined by a lack of interest in relationships and a flattened affect. Schizotypal have features of both, as well as eccentricities like magical thinking and peculiar behaviors or appearances. Moving on to cluster B disorders. First up, we have borderline personality disorder. This is the only R1 personality disorder, so there'll be more detail included here. We'll go through the criteria in a second, but BPD at its core is a disorder of pervasive instability, including issues with emotions, relationships, self esteem, self sabotaging behaviors, and impulsivity. BPD affects 1 to 6% of Australians during their lifetime and is more common in women. And as you might know, BPD is highly stigmatized by both the general public and clinicians, and it's just something to keep in mind when you see patients on the wards and when you observe nursing and medical staff interacting with them. BPD has a high mortality rate, and life expectancy of people with it is estimated to be nearly 20 years less than other Australians. And from 2009 to 2013, 10% of all suicides in Victoria had a diagnosis of BPD or symptoms consistent with the condition. So BPD has no single cause, but is likely a result of complex genetic, social, and environmental factors. There is a strong link between BPD and a past history of trauma or abuse. However, people with no history of trauma can also develop it. So the current theory is that some people may have a higher biological or genetic vulnerability to developing BPD, and adverse childhood events can further increase this risk. So BPD has similarities to a condition called complex PTSD or CPTSD. CPTSD is not described in the DSM-5, but it is in the ICD-11, which is the International Classification of Diseases. So CPTSD, as you can see in this graphic, has aspects of PTSD and BPD. Like BPD, patients with CPTSD also deal with affective instability, issues with identity, and social challenges. Some have argued that BPD should be renamed as CPTSD to acknowledge a strong trauma link and to mitigate some of the stigma BPD patients face, but at the moment, the two are still considered distinct conditions due to the differences illustrated here. So here's the DSM-5 criteria. This is another one that I think is worth remembering. As I said earlier, BPD is all about instability in different aspects of life, indicated by at least 5 of the 9 criteria. So, number 1, patients experience identity disturbance, meaning they have issues with the way they see themselves and their sense of self. Number 2, affective instability, sometimes presenting as mood swings. Number 3, chronic feelings of emptiness. Number 4, suicidal behaviors, which is how a lot of BPD patients end up in inpatient wards. Number 5, patients may experience symptoms that seem psychotic, like paranoid ideation, but this is generally quite transient and stress related. Number 6, people with BPD struggle with abandonment issues and frantically avoid real or imagined abandonment. Number 7, impulsivity in at least 2 areas that are potentially self damaging. For example, spending, sex, substance use, all of which are quite concerning from a risk assessment point of view. Number 8, problems with anger, which may present as frequent displays of temper, constant anger, or frequent physical fights. Lastly, patients with BPD often exhibit a pattern of unstable and intense personal relationships, characterized by alternating between extremes of idealization and devaluation. This is also known more colloquially as splitting, and means that they have periods where they can quickly transition between absolutely adoring a partner and then becoming intensely angry and hateful towards them. Of course, this behavior is not just reserved for partners. So here's a helpful mnemonic that you can use to help remember the criteria. And if you don't like that one, here's another one. And here's just a graphic breaking down the symptoms. Moving on to management, I'll break down the treatment for BPD once again in a biopsychosocial framework. Biological agents are only really used short term for patients needing acute intervention like sedation, and medications should not be primary therapy for BPD. The only high yield thing for exams is actually the psychological management, which is dialectical behavioral therapy or DBT. DBT is a type of psychotherapy based on CBT, and it teaches patients skills like emotional regulation, mindfulness, and aims to address life threatening and quality of life interfering behaviors. Socially, clinicians should help family and significant others through psychoeducation, also referrals to family counseling if they prefer. One thing to remember is that BPD patients should avoid admission wherever possible, as it can be detrimental to their overall recovery by reinforcing pathological help seeking behaviors, as well as issues with treatment interfering behaviors such as transference, countertransference, and splitting. I'll leave a link in the presenter notes where you can learn more about these behaviors. So here we have Angela. Angela is a 26-year-old woman who presents with a history of non-suicidal self-injury, specifically cutting her arms and legs since she was a teenager. She's attempted suicide twice in the past 10 years by overdosing on prescribed medications. Angela describes a long-standing pattern of changing her hobbies, style of clothing, and sometimes even her job based on who is in her social group. At times, she thinks that her partner is the best thing that's ever happened to her and will impulsively buy him lavish gifts. At other times, she admits to thinking, "I can't stand him," and will ignore or lash out at him, including yelling or throwing things. Immediately after doing so, she reports feeling regret and panic at the thought of him leaving her. Angela reports that before she began dating her current partner, she sometimes engaged in sexual activity with multiple people per week, often with partners whom she did not know. So, from Angela's case, we can see a few key features of BPD, including chronic suicidal behaviors, identity disturbance, relationship turmoil, abandonment issues, as well as past impulsive sexual behaviors. So, next in Cluster B is antisocial personality disorder. ASPD is only diagnosable in adults. In children, conduct disorder will be the closest equivalent. The behaviors of people with ASPD show a persistent disregard for the rights of others and a lack of remorse when mistreating others. So this can manifest in many ways, including deceitfulness and frequent forensic involvement. People with ASPD also can be quite irresponsible for themselves as well. For example, not paying their bills, randomly quitting jobs, and they are often quite impulsive. Moving on to narcissistic personality disorder, people with NPD are quite grandiose, arrogant, and self important. This leads to a lack of empathy for others, as well as exploitative behavior such as taking advantage of others for their own benefit. So here we have Jimmy. Jimmy is a 31-year-old man who presents with features of grandiosity. He has an exaggerated sense of self importance and appears to feel privileged and entitled. He expects preferential treatment and has fantasies of unlimited success, power, beauty, talent, and brilliance. He lacks empathy and seems unable or unwilling to understand or respond to others' needs or feelings unless they coincide with his own. He tends to feel envious of and competitive with others and can be dismissive, critical, and arrogant. And finally, for cluster B is histrionic personality disorder. People with this condition experience excessive, rapidly shifting, and often theatrical, exaggerated emotions. They also seek attention through various means, including through their physical appearance. So, Amy is a 56-year-old female currently going through relationship problems with her partner, Mark. Mark is Amy's fourth partner that year, and Amy describes him as jealous and paranoid, saying that he thinks she is too provocative and seductive. When probed further, it is revealed that Amy enjoys flirting with men despite their relationship. During her interview, she openly flirts with the psychologist and resents the fact that he had to pay attention to another patient at her expense. She's emotionally labile and speaks dramatically. From Amy's case, we can see a few features of a histrionic personality disorder, particularly the attention seeking behaviors. So, in summary, for Cluster B, borderline personality disorder is defined by pervasive instability in many aspects of life. Antisocial disregards the rights of others, reckless, irresponsible, and remorseless, often having forensic involvement as a result. Narcissistic are grandiose, exploitative, and lacks empathy. Histrionic are dramatic, attention seeking, and emotional. And lastly, we have cluster C disorders. Beginning with obsessive compulsive, the main issue for people with OCPD is that it results in patterns of rigidity throughout their lives. They often have difficulties with work, their preoccupation with perfectionism and orderliness, inhibiting their progress and also making it difficult for them to delegate tasks. They may also be excessively devoted to their work at the expense of their hobbies and relationships. So, due to some shared aspects of the conditions, OCD and OCPD can sometimes be difficult to distinguish, especially because they commonly present together. I think the main difference between the two is that people with OCD find their preoccupations and obsessions problematic and usually want to be rid of them, whereas people with OCPD like living according to their rigidities and do not want to be rid of their rituals. So, here we have Mark. Mark is a 42-year-old single man who lives with his parents. He's been unemployed for some time because he has had difficulty keeping jobs. Most recently, he was not able to meet production demands at his factory job because he got consumed with making each package perfect before moving on to the next one. One weekend, when his family planned to visit grandparents, Mark started packing on Wednesday afternoon but did not finish packing until Saturday when it was too late to go. So clearly, in Mark's case, his employment has been impacted by his rigidity and extreme attention to detail. So next is dependent personality disorder. People with dependent personality disorder have a pathological need for approval and to be taken care of by others. They fear being alone, leading to behaviors like urgently seeking a new relationship when one ends. They doubt their own abilities to take care of themselves and make decisions, constantly seeking advice and reassurance from others. So Sally is a 27-year-old woman who works as an assistant. Sally's mother used her network to get the stable job for her daughter. Sally's consumed with pleasing her mother and even asks for her mother's advice on what to wear to the office every day. Sally consistently worries about pleasing others and her colleagues at work, even at her own expense. So clearly, Sally is dependent on her mother and constantly seeks advice and approval from her as well as her colleagues. Finally, we have avoidant personality disorder. People with avoidant PD believe themselves to be inferior to others, especially regarding social capabilities. They are particularly concerned with the possibility of being rejected or criticized in normal social situations. So lastly, we have William. William is a 35-year-old unmarried data tech presenting with various complaints, including social anxiety, low self-esteem, and social isolation. These issues are chronic in nature, dating back to childhood. William's most prominent fear was of being ridiculed when interacting with others. He avoids making excessive contact with people and struggles to accept invitations to social events from co-workers. He has kept the same job for some time as he is worried about taking a risk in applying for new positions. So here, William is displaying clear signs of social inhibition in work and life due to fear of being ridiculed. His low self-esteem could also point to feelings of inadequacy as well. So in summary, for the cluster C disorders, people with OCPD are pervasively rigid and inflexible. They often preoccupy with perfection and control. People with dependent personalities are uncomfortable being independent. They seek approval and guidance from others and are submissive and clingy as a result. People who are avoidant have feelings of inadequacy and inferiority. They also fear rejection and embarrassment, and this leads them to be socially inhibited. Before we move on to questions, I just want to quickly say that whilst I've covered each condition very briefly today and focused on examinable content, it's important to remember that patients with personality disorders are complex, and generalizations can be incredibly harmful, especially with the cluster B disorders. Exam questions often focus on the most prominent, obvious aspects of different conditions, because that's what we study. But each person's experience with a personality disorder is unique, and patients deserve empathy and understanding. So, with that being said, let's go through some practice questions. We'll go through about 13 questions. Please pause and read the question and options, come up with an answer, and then we can go through it together. So, this is question one. So, the answer for this one is BPD, and it's quite a typical BPD question. Rachel is presenting with suicidal behaviors in the context of an acute stressor, which is her argument with her boyfriend, as well as chronic threats to overdose. Rachel also experiences difficulties regulating her mood, which presents as mood swings. Question two. So the answer here is venlafaxine. Normally, in this case, a form of psychotherapy would be first line. However, as Sam is unwilling to explore his illness, starting with an antidepressant would be better. Here, the only option is venlafaxine, which is an SNRI. Oxazepam is here as well, but that's a benzo, so we only use that for short term. Question three. So the answer here is paranoid personality disorder. And what differentiates this from a psychotic illness like schizophrenia is that the paranoia this man is experiencing seems to be pervasive in his life rather than a single or a few fixed delusions. Additionally, his paranoia is specifically regarding the fidelity of his partner, and that is quite common amongst people with paranoid personalities as well. Question four. So here the answer is thyroid function tests, kind of like what I mentioned earlier. So here Jenny is experiencing anxiety and weight loss, which should immediately make you think of thyroid dysfunction. I'm not 100% sure about the difficulty hanging out washing, but I think that could be pointing towards proximal muscle weakness, which can also be caused by thyroid problems. So when you're getting anxiety and thyroid symptoms, you need to rule out hypothyroidism as a differential. Question five. So here the answer is oxazepam. So for maintenance anxiety therapy, we would use an antidepressant like fluoxetine or venlafaxine. But here this patient is clearly experiencing transient acute anxiety that will pass when the surgery is over. So benzos can be used in the short term. Additionally, psychotherapy and antidepressants would need more than a week to have an effect. Question 6. So the answer here is agoraphobia, and this is because this girl has anxieties about leaving the home due to the fear of becoming anxious, and this fear of panic itself is a hallmark feature of agoraphobia. Question 7. So the answer is thyrotoxicosis. Same as the question we did earlier, anxiety present with other symptoms of thyroid dysfunction should be investigated for organic causes first. Question 8. So once again, similar to the previous question, this patient needs acute anxiety relief in a very short time frame, so benzos would be the best choice. Question 9. So Catherine here is likely experiencing panic disorder, even though the stem is too short for you to really figure out exactly what's going on. But for panic disorder, CBT would be first line. Question 10. So here, this 28-year-old woman is experiencing a long history of impulsive behavior and self-harm, and the two together should make you think of BPD, and DBT is the gold standard therapy for that. Question 11. So here the answer is dependent personality disorder, and this is because Lynn is having difficulty making decisions and caring for herself to the extent that her 10-year-old daughter has to help out. She also worries about leaving alone and is even exhibiting clingy behavior towards a previously abusive partner. Question 12. So the answer here is histrionic personality disorder. So this is a big generalization, but in Monash questions, histrionic tends to be associated with jobs like acting. Sarah's also exhibiting exaggerated emotions and also attention-seeking behaviors as well as appearance. And last question. So the answer here is dialectical behavioral therapy. So similar to the previous question we did, Jane's history of abuse, trauma, suicidal self-harming behaviors, relationship turmoil all make you think of BPD, and for that, DBT is the gold standard therapy. So that's all for today. If you guys have any questions, please feel free to shoot me an email, and thank you for watching.